Incompatibility. Introduction. The Rh factor, that is rhesus factories, RBC surface antigen that was named after the monkeys in which it was first discovered. Rh incompatibility, also known as RHDs, is a condition that occurs when a woman with Rh negative blood type is exposed to Rh positive blood cells, leading to the development of Rh antibodies. Rh positive fetuses or neonates of these mothers are at risk of developing hemolytic disease of the fetus. Rh negative, meaning no D antigen. Rh incompatibility can occur by two main mechanisms. Commonly, when an Rh negative pregnant mother is exposed to Rh positive fetal RBCs. 1. Secondary to fetal-maternal hemorrhage during the course of pregnancy. 2. When an Rh negative female receives a blood transfusion that contains Rh antigens or Rh positive. It is the reason that blood banks prefer using blood type O negative or type O Rh negative as the universal donor type, especially in females. Pathophysiology. Once anti-D IgG antibodies are present in the pregnant woman's circulation and across the placenta and sensitize fetal red blood cells for destruction by macrophages in the fetal spleen. Transplacental fetal-maternal bleeding accounts for all cases of maternal Rh or D alloimmunization. Teeny or 0.1 ml quantities of fetal red blood cells gain access to the maternal circulation in nearly all pregnancies. The frequency and the volume of spontaneous fetal-maternal hemorrhage increase with advancing gestational age and are highest at delivery. Therefore, most first-born infants with Rh positive blood type are not affected because the short period from first exposure of Rh positive fetal erythrocytes to the birth of the infant is insufficient to produce a significant maternal IgG antibody response. As the diagram is, the first image shows Rh negative woman and the Rh positive man conceive a child. The second image shows the Rh negative woman with Rh positive fetus. Third image, cell from Rh positive fetus enter woman's bloodstream. Fourth image, woman becomes sensitized, antibodies form to fight Rh positive blood cells. Image 5. In the next Rh positive pregnancy, maternal antibodies attack fetal red blood cells. Diagnosis. History of prior blood transfusion. Rh blood type of the mother. Rh-BG of the father. 50% of Rh positive men are genetically heterozygous for the Rh antigen and therefore produce Rh negative offspring. When mating with Rh negative women, previous abortions, previous administration of Rh, IgG, APH, PROM, trauma, procedures, amino synthesis, synthesis or ectopic pregnancy. These are the main histories. Lab studies, prenatal care, determination of Rh and blood type, obtaining maternal Rh antibody titers. High levels of maternal Rh antibodies suggest that Rh sensitization has occurred. Further tests, amino synthesis or chordosynthesis. Examine blood from the umbilical cord of the infant. Because of its short half-life, Rh-IgG routinely should be administered once at 28 up to 32 weeks and again within 72 hours after birth to all Rh-negative women. 300 microgram of Rh-IgE IM for pregnancy greater than 12 weeks, ectopic pregnancy and amino synthesis. 50 mcg for early termination of less than 12 weeks because of minimal hemorrhage. The exact mechanism by which passive administration of Rh-IgG prevents Rh immunization is unknown. The most likely hypothesis is that the Rh immune globulin coats fetal red blood cells containing Rh antigens on their surface. Management of unsensitized pregnancy. Blood typing at first visit. If negative, husband's typing. If husband is also negative, then no treatment. If husband is positive, if possible, homo or hetero, do indirect compass test of mother or antibodies. Negative, good. Repeat ICT at 28 weeks. Negative, ICT at 35 weeks. Negative, observe. 300 mcg of Rh-IgG IM for pregnancy greater than 12 weeks, ectopic pregnancy, APH, IUD, and amino synthesis. 50 mcg for early termination of less than 12 weeks because of minimal hemorrhage. At birth, cord blood for Rh typing of baby. If Rh negative, be happy. If Rh positive, test mother's blood for indirect comp test and infants for direct comp test. Negative or weakly reactive. 300 mcg immunoglobulin positive sensitized hemoglobin and bilirubin estimation of the infant. Treat the infant. Cause of sensitization. Misinterpretation of maternal Rh type, Rh positive blood transfusion, unprotected pregnancy and lower inadequate dose, or improper use of IgG on previous occasion. Fetus Rh negative observation. Fetus Rh positive intrauterine transfusion of Rh negative blood as indicated. Timely delivery anytime after 32 weeks. Management of the infant up to 8 weeks. In case of severely sensitized women, consider medical termination of pregnancy and sterilization. Treatment: fetal HCT less than 30%, equals to or greater than severe fetal anemia. Gestational age greater than 34 weeks. Baby must be delivered. And the gestational age less than 34 weeks. Intrauterine transfusion. O negative blood type. Intraperitoneal transfusion less than 18 weeks due to limited visualization. Packed red blood cells are deposited into peritoneal cavity, which will be absorbed by the lymphatic system. Intravascular transfusion 18 to 35 weeks. After 35 weeks, the procedure is generally considered riskier than late preterm delivery for neonatal treatment of severe anemia. Future pregnancy. Each subsequent pregnancy after the first affected pregnancy is likely to manifest more severe fetal hemolytic disease. 1. Gestational surrogate insemination with donor sperm from an Rh or D negative donor or implant from woman's fertilized egg. 2. If the father is heterozygous, in vitro fertilization pre-implantation. Genetic diagnosis for selection of Rh or D negative embryos and transfer of only these embryos. Prevention of Rh-Incompatibility. Premarital counseling. Ambitious. Proper matching of blood, particularly in women before childbearing. Blood grouping must for every woman before first pregnancy. Rh positive blood transfusion 300 mcg immunoglobulin or minimum. Proper management of unsensitized Rh negative. Treatments. The end. Galatoma